welcome to the podcast. Today's topic is lower extremity peripheral nerve blocks. I'm Ferrell, Associate Professor of Anesthesia, Medical Director of the Acute Pain Service. We'll try to get through this as interestingly as possible, if that's even a word. No financial disclosures to report. The only person putting in my paycheck is the University of Kentucky. So all of these items are my hallucinations. Today we're going to be talking about ultrasound images of lower extremity blocks, the anatomy around those structures, and some of the risks that are associated with each customized block. So we'll be looking at the lumbar plexus, obturator, lateral femoral cutaneous nerve, adductor canal saphenous, the sciatic, including all the different approaches, ankle, and also in this we'll be looking at the iPACK block. I'll get that towards the end, so that'll be something fun and new. So here looking at the lumbar plexus, these are all the root segments that come into what will give rise to all the branches that we'll discuss in subsequent slide. So we're looking at here at the picture of the second, third, and fourth ultrasound picture as kind of a vertical axis. We're looking at kind of the short axis of the transverse process segments. So the reason that we don't commonly use ultrasound with this block like in plane is that the angles of approach for where the needles would come in, it's kind of difficult to get to those segments around the transverse process, and the segments that we're kind of targeting are deep to those segments as well, so you can't see past the bone particularly well. So in terms of the actual conduct of this block, that's the reason we don't really use like an in-plane technique for this, is it's difficult to get the needle where you want it safely. Again, another image kind of looking at the picture on the left, being the classic anatomic kind of L4 spinous process segment, where you're at the tuft line, the intercostal line, kind of the top of the hips where the A marker is, about 5 centimeters off midline where the insertion point is. And the ultrasound image is kind of going through and looking at the vertical orientation of where we're looking at those things in short axis. So the branch segments from the lumbar plexus includes femoral, lateral femoral cutaneous, the obturator, genitofemoral, ilioinguinal, iliohypogastric nerves. So all those branch segments come from lumbar plexus. So it's like root segments of L1, 2, 3, 4, 5, sometimes T12, sometimes S1, but really just kind of in those lumbar segments of what gives rise to the plexus. We already talked about using ultrasound in terms of, I use it to identify the location of where we're going to put the needle, how far in the needle is going to go before it contacts the osseous structure, and how far out we can go before we're missing the lateral aspect of the transverse process. So that's why we're using ultrasound, kind of give us an idea of a peek inside the black box when we're doing the procedure, that we can really identify where our target's going to be approximately. Keeping in mind that when you're using the ultrasound probe and estimating depth, you're pushing on the skin, so you're contracting some of that depth, so your overall needle pass is probably going to be a little bit longer than what you would expect, but no more than probably about a centimeter or so, depending on the body habits of the patient, how much slack tissue you're pushing against to get the picture. I use a nerve stimulator commonly during this block, just because you want to demonstrate that when we're getting the stimulation of those segments, that we kind of have a target. We know where our needle is and what we're targeting, where we deliver the local anesthetic. The risks of this block, really the kidney and the ureter are kind of at these segments, kind of a little bit further outside lateral, but if the needle passes too deep, those are things that could be hit. The aorta, the vena cava, depending on which side you're on, and then retroperitoneal bleeding. So the same anticoagulation guidelines that you would use for neuraxial, we use for this because it's considered a deep block. So the retroperitoneal bleeding can be substantial. So if they just took their Plavix, probably wouldn't do this block. This is good for things like hip surgery, femur fractures, things that are kind of proximal and high up. That's where we're really using these items to target the lumbar plexus. Obturator block. So this block is for coverage of kind of the medial aspect of the leg. So all the things that are adducting, that pull stuff in. So for like an above the knee amputation, that's where you're going to do this block to get coverage on the medial aspect, kind of above the knee on the inside of the leg. So as we're looking at where we put the probe on the left side picture, the right side, We have the longus brevis magnus segments of the adductors. So Lyndon Baines Johnson was a president, and longus brevis magnus are your muscle segments. So the anterior branch, as we can see labeled here, is on the superficial aspect. So we're looking kind of for this sandwich picture, these layering of muscles. Pectineus is labeled as kind of the lateral structure, and then the posterior branch is on the deep layer of the between magnus and brevis. So you're really just kind of doing this as a field block. You identify these tissue planes. You won't always necessarily discretely see like nerve structures like they have pointed out here, but as long as you put local anesthetic in both of those segments, you'll have coverage. Usually put about 10 milliliters total, so about 5 deep and 5 superficial. I always do the deep block first because the imaging underneath it will be worse if you did the superficial block and then the deep. So the obturator, we talked about, is the medial aspect of the leg. And when we're doing things like ACLs, we have some times people will point to the middle aspect of their leg, and that's where we're getting sparing from whatever coverage we didn't get from the femoral or from an adductor canal. It's really just a sensory aspect of this. I mean, if you could try to do stem, you might have some like local stimulation of muscle itself, but this is mostly just kind of a sensory branch. So, if you did stem, don't be surprised if you don't really get any major response, and anything you did get would be like the muscle itself. So there's no real major vessels in this segment, it's really just the muscles. We talked about the longus brevis and magnus. So, it's a pretty low risk block, high efficacy if the medial aspect's what you're missing. So the lateral femoral cutaneous nerve, so where the ultrasound probe is placed in these pictures, and we're looking at a cadaver segment as well. So we're looking at where the sartorius attaches up to the ASIS on the lateral aspect, and we're really kind of just below where the osseous projection of the bone is itself, and we're kind of looking in almost the inguinal crease just below it, and we're looking for the sartorius muscle. So in the next slide, we have the imaging where we're looking at the sartorius muscle, so SAM, and then the fasciolateral layers above it, and the lateral femorocutaneous nerve is kind of in that arc. So when I do this block, again, kind of just a 10 cc kind of field block, I just make sure I infiltrate just deep to that segment, kind of on the bottom of the sartorius, and then around that curve around to the top. So it's for the lateral aspect of the leg, just the outside part of the leg, and sometimes for like ACL surgeries that we do commonly here, when they point to the outside of the leg, that's typically the segment that's spared. Again, largely a sensory segment, really not a whole lot of motor affect from that, so really not much to stem, really no major vessels here, so low risk of bleeding or hitting something expensive. Femoral nerve blocks. So as we're looking at the cadaver dissection, so it's naval, lateral to medial, NAV, and then lymphatics. So looking at the nerve structure, what you'll notice from the cadaver picture on the left is that as this nerve comes out, it splays out into branch segments and things that go medial and lateral, what's going down to effectively the kneecap, and will give rise to the saphenous nerve. So important teaching point from that is that the further down you take this, as you're getting into the adductor canal and going down further, is that other sensory segments that are going to be going out medial and lateral, the further down you go, the more of those segments you're going to miss. So you'll be focused for what gives rise to the true saphenous. It just kind of goes down kind of the anterior medial aspect of the leg. But anything that may branch off of that will be missed higher. So whenever you have sparing from this, you'll notice that typically it'll be because the block was taken further down. So sometimes a repeat block may need to take it closer to the inguinal crease. So we're really targeting kind of the anterior thigh segment. It is a motor nerve, so you're going to get quadriceps, you want patellar snap from your stem. If you get sartorius, typically if you're stemming, you're too superficial and you need to just kind of go deep to wherever that segment is. It's usually right underneath it. So for all the knee surgeries, total knee arthroplasties, ACL's great for that. And then the risks of this segment, really don't want to hit the femoral artery. Now, if patients have had like a fem-pop bypass, really don't hit that, because the graft not going to close. You're going to put a hole in it, it's going to bleed out. They're going to have to have another surgery to fix the graft. So be super, super, super careful. If they've had a graft placed there, don't hit that. The surgeons tend to not favor this block just because when you're taking the true femoral, you're getting that motor effect. So patients will feel like they can ambulate. They can't, because they can't contract their quadriceps muscle, and they're going to fall. So that's where our surgeons really have some concern that we're doing something that takes away their ambulatory ability, and kind of working against some of the things, because they can fall down and tear up the repair. So something to keep in mind there. Saphenous adductor canal. So we've moved further down the leg. A true saphenous adductor canal is subsartorial. So that's why I have the segment here where we're looking at the sartorius, and we're just deep to that in the canal. So medially, we see our adductor segments, and then vastus medialis as well. This block is really kind of taken from a lateral to medial aspect, where we are putting in a volume in the canal, like right next to the lateral aspect of the femoral artery. Ideally, this should just be like a sensory block, so that's why this is a little bit more favored by the surgeons, because patients should have ambulatory ability afterwards. However, also keeping in mind that I mentioned before that the sensory segments can kind of branch out a little bit. So I cheat with this particular block, and from our previous cadaver slide, looking at what is also called the femoral triangle, like before the sartorius segment kind of really comes across where the femoral artery is. So I kind of cheat and do a hybrid where I'm up a little bit further, a little bit closer to the inguinal crease, and take the block kind of before I get to the true saphenous segment, just because I want that coverage that splays out higher. So this is the ultrasound image looking at it with, all right, moving on to the sciatic block. So in this particular image, we're looking at the anterior aspect. So the probe is just below the inguinal crease, medial aspect. Typically use a curvilinear probe for this block because we need a little bit more depth of penetrance. You'll look and see at this, the femur is located about 5 centimeters down. The sciatic nerve is a little bit more like the 6 to 7 centimeter depth. So orienting to this ultrasound picture that's on the left. So the femoral artery is superficial, lateral is screen left, the femur is that black kind of circle that's identified as femur. The nerve itself tends to be in kind of the bottom third of that circle that is the femur, and it's medial to that aspect. So you've got a couple different ways to come at this. You can come from lateral to medial, keeping in mind that you have to have a perfect trajectory to get under the femoral artery and over the femur to get to the sciatic nerve. So typically, depending on the orientation of the patient, I'll be coming from medial to lateral. In males, sometimes a little bit challenging because you're kind of having to push the scrotum and testicles up because you're really close to the inguinal crease in this orientation. But in that approach as well, there's nothing but muscles between you and the target. So you really can kind of have free range of motion in terms of getting down to the sciatic nerve and be able to target it. So you're kind of looking at the lesser trochanter segment in the medial aspect there. As the circle medially kind of tapers down deeper, that's the lesser trochanter. So when we're targeting the anterior sciatic segment, we're getting pretty much all of what is going to give rise to the sciatic, including all the distal branches segments as well. The other teaching point of this is that the posterior cutaneous nerve of the thigh, this is about the level where this is going to come off. So like an above the knee amputation, this is a decent block to do because you'll catch that as well. If you catch the sciatic nerve, pretty much anything lower than like a transgluteal, subgluteal, you'll miss the posterior cutaneous nerve of the thigh, and they'll have some sensation of the amputation going through the back part of the leg. So you got to catch the sciatic higher. Now for below the knee, it doesn't matter. because the posterior cutaneous nerve of the thigh, from a sensory aspect, kind of stops at the popliteal fossa. So if it's below the knee, you can catch the sciatic nerve, popliteal fossa or higher. But that's the branch point from that you got to pay attention to. You do get motor affect, obviously, from this because it's fairly proximal. The sciatic nerve, depending on what kind of needle you're using, sometimes can be challenging to stimulate just because it's a pretty big, thick nerve. It's lots of insulation, so the current has to be a little bit on the higher side to get it to really have effect. And you're looking for kind of any foot movement. So whether it's plantar flexion, dorsiflexion, medial or lateral, any of that movement, then you're on the sciatic nerve. We already talked about the medial approach, and then from the anterior sciatic, we don't hit the femoral artery. Certainly there can be kind of arteriovenous malformation segments that you can't really see. They're kind of buried in some of the muscles there. Rare that should be present, but I've seen that clinically a handful of times before. And then with this particular approach, we'll make sure that we don't necessarily get into the sciatic nerve and have any kind of structural degradation from hitting it with the needle. Parasacral sciatic is a less commonly utilized approach, but clinically very good. So what we're doing with this particular block, kind of start with the ultrasound picture on the left. We're up on kind of the pelvic brim in an angle orientation, kind of pointing towards the greater trochanter is what they're showing there. And then in the external picture that's below on the left side, we're sliding down along the sacrum. So in the ultrasound picture on the top, we're looking at a thinned out segment of the gluteus maximus, a little bit thicker segment of the gluteus medius. The black on the left of the ultrasound is just bone that's kind of the pelvis and sacrum. And then as we're sliding down, we're looking at a thickened section of the gluteus maximus. That black little wedge that's labeled P is the piriformis muscle. The sciatic nerve is just deep to that. So when you see that particular image, you've got a great target because you're looking at all the sacral segments that are giving rise to the sciatic nerve, and the nerve you're looking at in long axis right there. So you've got a great target. So the cadaver anatomy that's on the right of this slide, so we're looking at the piriformis muscle as it's kind of pulled up. Gluteus medius is just deep to that, and then the sciatic nerve comes just up under the piriformis. So it's a great approach for that. Also keeping in mind that just deep to the sciatic nerve in the ultrasound picture that's on the left is like the pelvic floor. So bowels, pelvic floor vasculature, all those things are in there. So you don't want to go past the sciatic nerve. You just want to get on top of it, put your local on top of it, and be done with that block. So this is a little bit newer block. It's very proximal sciatic nerve. You're literally at the transition of where the root segments have kind of come together to form what gives rise to the anatomic sciatic nerve. And you will get the posterior cutaneous nerve of the thigh. On this particular block, I've had some proximal segment of the injectate that's gone towards the root segments, and I've had some S4 or S5 segments that kind of pushed up in that. So sometimes I can get almost like a little saddle block from those root segments that are affected as well. So just keeping that in mind, that it can kind of push itself immediately a little bit. Because the sciatic nerve typically is a less vascular block. I don't know that I've seen any plasma concentration studies for this, so it's kind of one of those wild cards that I wouldn't necessarily expect a tremendous plasma uptake because there aren't any major vascular structures around here, but it's not something that's been quantified in the literature per se. All right, transgluteal sciatic, a little bit more conventional approach to this. So we're in kind of a hammock segment between, as we're looking at the probe placement in the left side picture, we're kind of pushing between the ischial tuberosity and the femur. So you can kind of feel the greater trochanter projection of the femur on the outside, and you want to be right in that divot in between. You're pushing on a thick segment of the gluteus maximus. Ideally, if you can get the leg flexed a little bit, it'll thin out the gluteus maximus and give you a little bit better approach to the segment, but not always can you necessarily get in that position, so you do the best you can. But the sciatic nerve tends to run in kind of that hammock segment. As you see that white line that kind of connects the ischial tuberosity and the femur, it's in that plane. So I've had instances where, I can't really see a discrete sciatic nerve within that segment, in and of itself. Put some volume in, and the tissues separate, and then the sciatic nerve kind of shows up. So sometimes you got to put a little volume in and try to tease out where that segment's running. Depending on where you're looking at it between those segments, sometimes you'll see the sciatic nerve closer to the ischial tuberosity, sometimes it'll be closer to the femur. It just kind of depends on the juxtaposition of, kind of how far up you're looking or the angle that you're looking, and where that nerve segment's from. Because right in that transition, it actually will go from kind of the ischial tuberosity over towards the femur. So if you're down a little bit further, it'll be a little bit closer to the femur. If you're up a little bit higher, it'll be closer to the ischial tuberosity. So the coverage from this segment, as we're kind of looking at the cadaver picture on the right, it's pretty much everything that sciatic nerve gives rise to. So it's proximal, get posterior cutaneous nerve of the thigh, and the stem. Sometimes I find that with the catheter needles in particular, it's a little bit more challenging to get that stem segment where we're trying to get some sort of affect of like the distal, dorsiflexion, plantar flexion, movement of the foot, just because the physical property of that needle is not great for it. The smaller like pine oak needles or the Biberon, the stimiplex needles, those are a little bit better just because they seem to translate the current a little bit better. So it's just kind of a property of the using different needles. I've had one transgluteal sciatic once upon a time when I was in training that had a toxicity event just because there was probably some sort of vascular structure somewhere in there we didn't discreetly see with ultrasound. But overall, we generally consider this to be the lowest risk of plasma concentration just because it's just kind of embedded in muscle tissue and doesn't have a particularly high uptake. There's no major vascular structures around. So on the whole spectrum of things, this should be the lowest plasma concentration of when we deliver these blocks. Moving on down, popliteal sciatic. So these are a common block that we do for like our ACL repairs, just because we can get the sensory segments where they do the hamstring autograft repair. So in the picture on the left, we kind of have the patient in supine position, leg elevated, and we're looking in the fossa itself. So in the picture that's on the right, we're kind of in that transition between looking at the tibial nerve and the common peroneal. So somewhere deep to that segment's the popliteal artery. And as we slide up and proximally, and it gives us a true sciatic, and we're not necessarily looking at the branch points, you can take the block in either place, but if they're doing kind of a high hamstring autograft, you really want to take the block about 5 to 7 centimeters above the fossa. So you want to see the sciatic nerve as it starts to go from kind of a round discrete structure to almost a little bit flatter structure. That's the transition point that I usually prefer to take that block. So moving on. Now, looking at the cadaver segments here, we're looking at the semitendinous, semimembranosus, and biceps femoris. When I typically do this block, I have the probe a little bit further lateral, where we're kind of on the biceps femoris, and I use the semitendinous muscle as like a rail to give us a head-on view of the sciatic nerve. So when I've got the probe physically on the leg, I usually have it screen left a little bit more on the biceps femoris. So we're getting the distal branches of the sciatic, the tibial and common peroneal. We're missing the posterior cutaneous nerve of the thigh because that came off up, around kind of the greater trochanter ischial tuberosity segment. And so our anatomic landmarks here, we're on the biceps femoris, pushing against the semitendinous, and the popliteal artery is just deep, closer to the femur. So anatomically, that would be anterior. So if we're kind of directing the needle too far anterior, the risk of contacting the popliteal artery. Now, one of the newer blocks that actually a former resident of ours discussed with me is something that he's doing for a surgery. It's called an iPACK. So it's infiltration of the popliteal artery in the capsule of the knee. So the target of this, which I have in the next slide, kind of discussing it a little bit more in detail, is we're really kind of going for sensory segments that don't have as much motor involvement, because the concern with total knee arthroplasty is that when they're setting the joint segment where they're replacing the knee, is that there's risk of stretch of the sciatic nerve. So the surgeons want to be able to assess the motor function of the sciatic nerve postoperatively to make sure that they haven't done anything that may have violated the integrity of the sciatic nerve with just mechanical manipulation of that segment. So this is a compromise to be able to deliver local anesthetic within the capsule in those branch segments that kind of come anteriorly from the tibial and common peroneal nerves. So we're giving sensory affect without having that motor affect, so they can really assess the function afterwards to determine whether or not they think they might have had some sort of nerve injury. But looking at this picture, you literally put this volume where the black segment that says femur, you're kind of just tracking just along the outside of that, kind of between the artery and the femur. So put some local anesthetic on the medial aspect, some on the lateral aspect. You can come at this from either side. You can come at from lateral to medial, medial to lateral. Doesn't seem to matter from what I've gathered from the literature, but the goal being you just kind of want to put it like almost like right on top of the femur, just create a line of local anesthetic. So there's no singular discrete structure like the tibial or common peroneal nerve like you would do for popliteal block, but that's what we're doing here. And the ultrasound picture that I got is from Jeff Gadsden from Duke. These are some of the points that I wanted to cover for the iPACK. Dr. Sinha from ASRA presentation 2012 kind of described this in what I could find for one of the earlier descriptions of this. Again, we're kind of just putting local anesthetic in like a 30 ml volume between the femur, so it looked like a lot of people are kind of putting about 10 to 15 kind of on the far aspect and a little bit in the middle, and then the other on the wherever your proximal aspect. So if you're going from lateral to medial, your first injection is on the medial aspect of the femur, come back to the middle part, put a little volume there, and then come back to the lateral aspect and put volume there. And then again, like I said, we're really targeting the sensory segments that are just what is going into the posterior capsule of the knee, where this arthroplasty, where the new joint is going, without really having motor effects of the tibial and common peroneal, because where that volume is going, you shouldn't have translocation of that local anesthetic to that bigger nerve structure that would be more superficial, be more posterior. So ideally, you shouldn't really have any local anesthetic turning that nerve off, and so they should just be sensory without the motor segment that they're looking to make sure they didn't hurt. And the last point I've got on the bottom is that for ACLs, because they're doing a hamstring autograft that goes up in the leg, we're going to miss that segment because we're too far down. So it would be okay for the knee joint itself, but we're still going to have pain in the back of the leg just from taking that hamstring autograft. But for like a total knee arthroplasty where they're not really going proximal, you should have good affect within that segment itself. Ankle blocks. This will be on your test. So there are 5 nerves of the foot and ankle. 4 of them come from the sciatic. So the sural, deep, superficial peroneal, and the tibial nerve all come from the sciatic. The only one that comes from the femoral is the saphenous. And you can see these distributions kind of roughly laid out here in terms of medial aspect of the ankle, lateral aspect of the ankle, and top and bottom. The deep peroneal nerve gets the web interspace between the first and second toes. They love to ask that question. The deep peroneal nerve also does the interosseous structures of the foot. The tibial nerve, which is not in this picture, but it runs behind the medial malleolus, gives rise to the intrinsic muscles of the foot. Sural nerves in the lateral aspect, and superficial peroneal is the dorsum of the foot. And the saphenous just kind of has that stripe on the anterior medial aspect of the ankle, and can even kind of come down almost towards like the first joint of the first toe, just kind of depending on anatomic distribution. This is kind of a walkthrough of where the needles are placed. So the top couple pictures kind of showing the deep and superficial peroneals. The bottom right picture is the sural nerve approach, and then the bottom left is the tibial nerve approach. So then the saphenous, actually I think the saphenous is the kind of the top right, and the superficial peroneal is the bottom middle. So in the deep peroneal is the center top. So those are your needle placements. Basically, you can get 5 nerves from 4 needle punctures. So we're getting coverage of the ankle, distal foot, toes. It's an easy field block. You can use ultrasound, but it's not necessary. It's small volume, small nerves, and just putting the volume where the nerve segments run, easy coverage. Again, saphenous is the only one not from the sciatic. The other 4 are from the sciatic. We talked about the deep web space between the first and second toes. The tibials, all the plantar surface of the foot, and the sural nerve actually has discrete branch segments from the tibial and common peroneal nerves. And I had this wrong for a very long time because anatomically I just considered the sural being the lateral aspect of the leg. Common peroneal goes lateral, that it was a discrete branch from that. It's not. So it has its own segments that come from both the tibial and common peroneal. These are the references, things that I used for some of the slides, and previous references also listed. Any questions, comments, derogatory remarks can be emailed to Shelley, SHELLY.Ferrell, FERRELL, @uky.edu. Thank you for your attention, and hope we all learned something.